Hello students, welcome to MedEd NExT, your very own place to learn medicine and allied subjects integrated way. And today we are connecting to have one more such integrated session. This is your host Dr. Santosh Patil, and with me I have Dr. Sandeep Sriram who will be covering the surgical aspects in today's session. Now, what are we going to do in today's session? We will be discussing acute care neurology. There are a lot of diseases which are relevant in the acute setting, and the focus is on that. We have already done plenty of sessions where we have discussed cold neurology, right, chronic diseases, and in the coming sessions we will be discussing plenty more diseases about cold neurology, but today's session is primarily focused on acute care neurology. Now, questions may be framed by the medicine faculty or the surgery faculty when it comes to your exam. At the same time, now there is an emerging branch called emergency medicine. Now, emergency medicine also might represent questions coming from both surgical as well as medical acute care neurology. So the focus is that. Now, what are we going to discuss? We will be discussing the acute ischemic stroke and the trauma related to the central nervous system, because the presentation may be similar. The management is totally different, right? Okay, so let us begin first with the acute ischemic stroke. Now, let me define you what is acute ischemic stroke. See, if you say that hemiplegia is acute ischemic stroke, would I agree with that? The answer is no. If you have, let me say in the motor cortex, if there is a tumor, the patient can still present with hemiplegia, right? Can we call it a stroke? No, right? At the same time, if there is, let me say in the pyramidal tract or somewhere in the journey of the pyramidal tract, if there is an abscess, brain abscess, patient might present with hemiplegia. So can we say he has got acute ischemic stroke? No. Then what is acute ischemic stroke? First thing, let me define what is stroke. Stroke is focal neurological deficit, which is presumed to be of vascular origin. Focal neurological deficit, which is presumed to be of vascular origin. So the source or the reason for someone to develop the deficits is something to go wrong with the blood vessel. Now, what can go wrong with the blood vessel? Either a clot can occlude it, causing ischemia to the tissues supplied by it, or there can be hemorrhage or bleeding into it. So we classify the stroke into ischemic stroke and hemorrhagic stroke. Okay, so from the medicine perspective, I'll focus mostly on the ischemic stroke, which is in fact the most common cause or common form of stroke. Okay, so now coming to the acute ischemic stroke, let me first begin with enlisting of important risk factors. Understanding risk factors is important because if you know the risk factors, you can probably mitigate the risk factors and reduce the chance of development of stroke in those patients. And there are few MCQs that can be asked from the risk factors aspect. Number one, the first MCQ point is, what is the most common risk factor? The most common risk factor is obviously hypertension, because hypertension increases the risk of atherosclerosis. Thus, it can cause the occlusion of the vessel. Similarly, hypertension can cause left ventricular hypertrophy. Left ventricular hypertrophy can cause left atrial hypertrophy. Left atrial hypertrophy increases the risk of atrial fibrillation. And we know whenever there is atrial fibrillation, in your Virchow's triad, one aspect is already satisfied, that is the stasis of blood. In the fibrillating atria, there can be stasis of blood, a clot can form, that can get embolized, and that can cause stroke. So hypertension is the most common risk factor for stroke. Second question that they can ask you is, what is the most potent or the strongest risk factor? The strongest risk factor is diabetes mellitus. Diabetes mellitus is the most potent or the strongest risk factor for the development of stroke. If you want to know the hazard ratio, it is 6. That is the highest. Then the third thing they will ask you is, if you treat these risk factors, will we be able to reduce the risk of developing stroke? Absolutely yes. But treating which risk factor reduces the risk maximally, or in other words, the intervention for which risk factor reduces the risk maximally. The intervention for the atrial fibrillation reduces the risk maximally. If you treat diabetes to the target HbA1c, you may not have a great risk reduction because there are other factors which are contributing to the risk in those patients. Same I can say with respect to hypertension, but the mitigation of atrial fibrillation as a risk factor reduces the risk maximally. Maximum risk reduction can be achieved there. But how do we mitigate the risk? By using anticoagulation, right? Anticoagulation. Clear? That is the third MCQ point. Beyond that, the other important risk factors include the carotid artery stenosis, then hyperhomocystinemia, obesity, sedentary lifestyle, and dyslipidemia. These are important risk factors. Obesity, sedentary lifestyle, dyslipidemia. These are important risk factors. Okay, so we have already understood the risk factors and what MCQs can be asked from this. Now, moving on to the clinical features of acute ischemic stroke. Can I pinpoint any specific finding to say that this is the clinical feature of acute ischemic stroke? No, right? The clinical manifestations in neurology always depend on which structure is getting affected or damaged. The most common territory where the stroke happens is MCA territory. And because MCA territory strokes are the most common, we can say that majority of the patients are going to present with the hemiplegia, with or without the speech disturbances. That is the most common presentation. Hemiplegia with or without speech disturbance, depending on which lobe is affected, whether it is dominant or non-dominant. That is the most common clinical presentation. Clear? Now, in the previous video modules, you have already learned about the hemiplegia. How do we localize the lesion if the patient presents with hemiplegia, right? So if it is a cortical lesion, patient might have speech disturbances, altered higher mental functions. At the same time, if it is a subcortical hemiplegia, we know that there will be a dense hemiplegia. And if it is brainstem hemiplegia, we know that there will be what is called as crossed hemiplegia. Those things you're already familiar. We don't need to elaborate again here. But remember, hemiplegia is the most common presentation. But other forms of presentation can happen. Isolated speech disturbance, right? Monoplegia, those kind of presentation can happen if there is a vascular insult. Okay, point number 1. Now, the most important point is, just like how the time is myocardium when it comes to MI, similarly, time is brain, time is neurons. So if you make significant loss of time in recognizing the stroke and treating it, we might end up losing large number of neurons, and probably we will send the patient home having maximum focal deficits. So for that matter, what is important is early recognition of stroke. Early recognition of stroke. Now, how do I early recognize the stroke? There are 2 things to remember here. The early recognition tool that helps the paramedics and laymen and even the patient attenders to recognize the stroke early is what we call as FAST. So it's my humble request to all the students is that be aware about what is called as FAST and educate the patients attenders in whom you have already identified risk factors: hypertensive, diabetic, right? Already known ischemic heart disease, dyslipidemia, hyperhomocystinemia. Those patients, their attenders, educate them about FAST. Now, what FAST stands for? F is for facial asymmetry. F is for facial asymmetry. Okay. Then A stands for arm weakness. Arm weakness. And S stands for speech abnormalities. Speech abnormalities. T stands for time. So all we need to do is tell the patient attenders that keep watching your family member or the patient who is having risk factors for development of any facial asymmetry and development of any one arm weakness or any disturbance in speech. If any one of these FAS are found, without wasting time, time here elaborates the importance of time. Without wasting time, seek medical help. Preferably get the patient moved to the nearest medical center. This way, a layman can probably identify the stroke early. But we are doctors and the onus is on us to identify stroke even before the hemiplegia is evident. Is it possible? I can give you plenty of stories where patients are brought to the hospital where they don't have the evolved hemiplegia. Then it is missed, patient is sent home, and then he comes back with dense hemiplegia, and then in such cases, you're also vulnerable to be sued from the patient's party, right? So how can we early recognize stroke? For early recognition of stroke by doctors, there is a sign called as pyramidal drift sign. Pyramidal drift sign, which is also called as pronator drift sign. Pyramidal drift sign or pronator drift sign. In any patient you're suspecting that there may be a stroke, all you need to do is ask the patient to keep his arms outstretched like this in a supine position. And as they keep it outstretched, if there is any side pyramidal tract lesion, then the outstretched arm from the supine will become pronated and it will drift away. They will not be able to hold it in supine position. That is what we call as pronator drift sign. So if you have it, this is the earliest sign of pyramidal tract damage. Repeatedly asked MCQ, the earliest sign of pyramidal tract injury or damage, that is pyramidal drift sign. This is the earliest sign. Okay. This is again an important MCQ point. So if you notice this, you have to get going and start treating the case as an acute ischemic stroke or acute stroke per se, so that you don't waste time in further management. Okay, so this is about the clinical features. Now, once I've suspected that patient might have a stroke based on the clinical features, then comes the question of how would I proceed further, right? We probably need an investigation, and repeatedly asked MCQ, what is the investigation of choice? The investigation is mainly required not for confirmation of stroke. Your clinical judgments are often accurate, but we need it for differentiation between the two types of stroke, which we have learned in the early part of this session, right? There can be a ischemic stroke or a hemorrhagic stroke. There can be bleeding into the brain parenchyma, or patient might have developed ischemia. Because the management is going to be different, it's very important for us to identify which type of stroke it is. So what would be the investigation of choice? Number one, we can think of doing MRI, we can think of doing CT, maybe you can also think of doing the nuclear imaging, but the investigation of choice is CT scan of the brain. Simplest reason for that is CT is much more sensitive for identification of bleed. I'm not trying to look for the infarct here. What I'm trying to look for is whether there is bleed present or not. How will it help my differential diagnosis? Well, if there is no bleed in the brain in a patient who presented with focal neurological deficits or hemiplegia, for all practical purpose, it will be because of ischemic stroke. So if you ask me, sir, what about if there is a tumor and patient has hemiplegia because of that? Tumor CT may not be able to identify. And if there is no bleed, we might mismanage the case as the ischemic stroke. The answer is, if there is a tumor, patient may not have such an acute presentation, right? There will be slowly progressing as the tumor is expanding, his focal deficits will be evolving. So that evolving presentation will probably go in favor of a space occupying lesion. But if it is an acute presentation, for all practical purpose, we take it as because of the ischemic stroke if there is no bleed in the CT. The second question, if the examiner wants to confuse you, whether you want a CT which is plain or with contrast. Plain CT is more than enough to differentiate between the bleed and no bleed, and that is more than enough because we don't want to waste time either. So plain CT is preferred. There is no need for contrast. Now, once I do the CT, I've already told you my question is whether there is bleed or not. If there is no bleed, for all practical purpose, it is ischemic stroke, and I will manage accordingly. But just because examiners might ask you some MCQs around this, there are two important points to note. What is the time taken for the infarct to be evident on the CT scan? It is usually more than 6 hours. Within 6 hours, you will not see a clear-cut infarct. That is the point. Then is there any sign which we can see during this period? See, we have stopped the blood flow to a particular part of the brain. So that tissue that is dying, it will change its architecture and it will be evident on the CT scan 6 hours down the line as an infarct. But we already know that the blood in any place, if it is clotted, would look white on the CT, right? So if the artery which is blocked, which large segment of the artery is blocked, we may be able to see it then and there itself. As soon as the artery developed a clot on the CT, it may be evident, and that is in fact the earliest radiological sign. And what is it called as? It is called as dense artery sign or dense MCA sign, because MCA is the most commonly affected artery. You can call it as dense artery sign. If you want to call it as dense MCA, fine, because that's the most commonly occluded artery. The other sign that we might see within 6 hours is called as loss of insular ribbon sign. Loss of insular ribbon sign. So we know that in the brain, there is white matter in the core and there is gray matter in the periphery. There is some demarcation which we can see on the CT scan between the white and gray matter. That demarcation can be lost. So we call it as loss of insular ribbon sign. Loss of insular ribbon sign. That is also one more sign we might see within 6 hours. Okay. But in the absence of it, it makes no difference. If there is no bleed, that is a case of acute ischemic stroke for me. Now, once I've made the diagnosis of acute ischemic stroke, then comes the question of management. Okay. So what is the best management strategy available for any patient with acute ischemic stroke? I will give you 3 approaches which are possible. Number 1, you can think of giving antiplatelets. Number 2, you can think of giving thrombolytic agents or thrombolysis. And number 3, there is an evolved technique called as mechanical thrombectomy. It is exactly similar to what we do for angioplasty, right? Mechanical thrombectomy is basically an interventional radiologist or a neurosurgeon or an interventional neurologist will enter into the carotid artery. He will find out the place where there is a block. He will clear it, mechanically clear it, same as your angioplasty. So these are the three strategies which we can employ. Among these, the best result that is possible is with mechanical thrombectomy. Now, if you want to see the beauty of mechanical thrombectomy, you can go to my Facebook page, and there I have shared a patient video where the interventional radiologist is recording the video and doing this procedure. Patient has got dense one-sided hemiplegia, and as soon as he retrieves the clot, he asks the patient to start moving the limb, and patient starts moving limb immediately. So if it is done within time, it can give you beautiful results. So you will be able to minimize the disability significantly. But to help the patient, we should know what are the indications. Where is it beneficial? Best treatment is mechanical thrombectomy. So first, let me begin with the indications for mechanical thrombectomy. The indications for mechanical thrombectomy are: number one, a patient with acute ischemic stroke presenting within 6 hours of the onset of symptoms. Presenting within 6 hours of the onset of symptoms, where the acute ischemic stroke is due to occlusion in a large blood vessel. That is an extremely important point, because if it is a distal branch of your MCA or ACA or PCA, the interventional radiologist may not be able to reach that part to clear the clot. So then comes the question, what is this large blood vessel? The carotid artery, the internal carotid artery, then the M1 segment of MCA, these are considered as large blood vessels. So if there is a clot in the internal carotid artery or the M1 segment of the MCA, we have a level 1 evidence to say that this can give you a good result. So this, if you remember this, that's enough. Like, we don't need to remember the levels of evidence at this level. Okay, so this is the indication. Now, if you ask me what are the contraindications, there are no major contraindications for this process. So you can take it up for any patient who has a large blood vessel occlusion presenting with acute ischemic stroke within 6 hours. Okay, so this is one approach. Now, the next best approach is thrombolysis. That is the second best after mechanical thrombectomy. Now, what do we do in thrombolysis? What we do in thrombolysis is we inject the patient drugs which can dissolve the fibrin. Fibrin plugs can be dissolved. That is what we do. Now, we know plenty of drugs, right? Starting from fibrin non-specific drugs like streptokinase and urokinase. And we also know fibrin specific drugs like your RTPA, retiplase, tenecteplase, all those. Only drug that has been US FDA approved for the thrombolysis of stroke patients is RTPA. Rest of the drugs, though we use it in practice, they're not yet FDA approved. RTPA is the only drug which is US FDA approved, and that's obviously an important MCQ point. Okay, but thrombolysis, whatever MCQs they've asked in the past, are mostly about indications and contraindications. Okay, so let me first begin with what are the indications for thrombolysis. Any patient of acute ischemic stroke who presented within 4.5 hours of the onset of symptoms. Acute ischemic stroke presenting within 4.5 hours of the onset of symptoms, right? Having a infarct area or ischemic zone less than 1/3 of the MCA territory. Infarct or ischemic zone less than 1/3 of the MCA territory. Why this is important? Because if there's a larger infarct, it might develop the hemorrhagic transformation. So once we give the thrombolytic, it might develop hemorrhage, and it will add to disability rather than benefit the patient. Okay. Now, there is one important point to note here is that the contraindications. What are the important contraindications? The contraindication number one is the blood pressure. Contraindication, BP more than 185/110. BP more than 185/110 is a contraindication, but please mention it in your bracket that it's a contraindication where BP is not controlled to less than this value despite treatment. So in the bracket, we can always mention despite treatment. That is important because if a patient presents to me, let me say he presented within 1 hour of the onset of symptoms, I still have 3.5 hours of time. If I can get the BP below this value, I can still go ahead with thrombolysis. If I'm not able to achieve the BP value less than 185/110, or I use up all the available time of that 4.5 hours to bring the BP and still not control, only then it remains a contraindication. Just because the patient presented with a BP of 200, 120 doesn't mean it's a contraindication. Make your attempt to bring it down. If you can bring it down, you can go ahead with the thrombolysis. Number 2 important contraindication is recent major surgeries. Any recent major surgery obviously increases the risk of bleeding, and we have to be careful about it. Recent major surgery. In some of the books, they mention any infarct which is more than 1/3 of the MCA territory is a contraindication, which if it is not an indication, it fits into there, right? So we don't need to specifically remember that, but be aware of it. Okay, so indication, contraindication, we are familiar. Now coming to the last aspect, that is antiplatelets, right? We can also call it as conservative measure. Antiplatelets, we can say conservative measure. In the antiplatelets, should we give single agent or dual agent? That's the question. Should I give only aspirin or 2 agents? The answer for that is 2 agents are better than 1 agent in the acute management. So we call it as dual antiplatelet therapy, DAPT. So currently DAPT is recommended for first 3 weeks, and after that a single agent should be chosen. DAPT is superior for first 3 weeks, DAPT, and after that a single agent. What should be choice is left to patient's parameters, right? Should you choose aspirin or should you choose clopidogrel? Depends on what other drugs he's having and its interactions. Okay. Now, how long the antiplatelet should be continued? Whatever single agent that you will continue after 3 weeks, how long it should be continued? The answer is lifelong until and unless a contraindication emerges. Like in future, if he develops some GI bleed or if he develops a hemorrhagic stroke or something, then it is a contraindication. Otherwise, it should be continued till then. Okay. Then the next question, what is the role of statins? What is the role of statins? The role of statins is, it is recommended we have to use high intensity statin for lifelong until and unless there is a contraindication. Statins reduce the risk of secondary event, one more stroke from happening. Statins reduce it. So it is recommended, but high intensity statin. Now, what is high intensity statin? Whenever I ask this question, students say, sir, atorvastatin, sir, rosuvastatin. The answer is nothing like that. Any statin at a particular dose becomes a high intensity statin. So it is dose dependent. For atorvastatin, it is 80 milligrams. 80 milligrams of atorvastatin is high intensity. Similarly, for rosuvastatin, 40 milligrams of rosuvastatin is high intensity. If you're using the lesser doses, it becomes moderate intensity, or further lower doses, it becomes low intensity. So atorvastatin 80 or rosuvastatin 40 milligrams is high intensity. Okay, clear? So now what are we left with? What are we left with is the decision making, and that is where the beauty of medicine comes into picture. So at your disposal, you have 3 approaches. You can manage conservatively by just giving antiplatelets. You can go for thrombolysis, or you can go for mechanical thrombectomy, right? The best thing we know is mechanical thrombectomy. If the patient is presented within the window period, that is the one thing to go for. But what if, let me give you a scenario. There's a patient who has presented 4 hours after the onset of symptoms. He meets the indication for the thrombolysis. He meets the indication for mechanical thrombectomy. In such cases, what should we do? See, if someone presented between 4.5 hours and 6 hours, then I have only one choice, that is mechanical thrombectomy. But a patient presenting within 4 hours, if he meets the indications for both, what should I do? If he meets the indications for both, right, then the guidelines recommend that you should do both thrombolysis as well as mechanical thrombectomy. That enhances the chances of full functional recovery. Not sending the patient home with hemiplegia, rather trying to send him home with the maximum ability. So the thrombolysis plus mechanical thrombectomy is recommended. And if you're going for both, the question is, what should I do first? Should I do thrombolysis first or mechanical thrombectomy first? Preferably, thrombolysis should be preferred first, for a simple reason is that if you've done the thrombolysis already, it makes it easier for the interventional neurologist or radiologist to retrieve the clot, because the clot is already partially dissolved. It's much more easier for him to retrieve it. But again, guidelines mention one particular statement, right? Do not delay the other waiting for one. So it is that because the thrombolytic drug is taking some time to arrive, right? Let me keep waiting and then I will go for the mechanical thrombectomy. No, if it is taking time, go ahead with the mechanical thrombectomy. You can administer thrombolytic agents during the procedure or post mechanical thrombectomy procedure, or vice versa. Do not delay the one waiting for the other. But if both are easily feasible, then thrombolysis should be preferred first and mechanical thrombectomy the next. Okay, so guys, this is a brief overview of how we handle a case of acute ischemic stroke. Right from the presentation, how we can make an attempt to early identify the cases, how we evaluate looking at the CT scan, and then once we have done the CT scan, how we manage. And I have given you a brief overview of how we make decisions. Now, you might not have understood everything in succinct detail. So what I would recommend is solve some MCQs where they force you to make a decision. They will ask you, how do you manage this case? Try to apply your understanding of the management of stroke, and then probably you will get a better idea of how the decisions are made. Okay, so with this, I will pass on the baton to Dr. Sandeep. Dr. Sandeep will talk about the surgical aspect of acute neurology. Over to you, sir.
Thank you very much, sir. Thank you. Thank you. Again, it's a refreshing talk that I've heard from the medicine point of view. It's been quite a while that I was being exposed to medical part of the neurological aspect. Again, nevertheless, all that sir have cleared it about the acute ischemic stroke. He has talked in terms of the medical prospect. We'll talk about the acute presentation also, right? So what do you mean by an acute presentation is we will be concentrating exclusively on the traumatic part of it. So I will take about the traumatic brain injury, right? Now, this traumatic brain injury is something which is very exciting and fascinating for us to treat when the patient is going to present to you in an emergency, right? Now, before going into the traumatic brain injuries, we also have the skull fracture the aspect of it. But today we'll be concentrating exclusively on the traumatic brain injury. Now, when I talk about traumatic brain injuries, I can divide them into two components. So what are the two components? Number one is your primary brain injury, right? It is a primary brain injury. Another one is what we call it as the secondary brain injury. One is the primary brain injury, another one is the secondary brain injury. What is the baseline difference between these two? When you read the textbook, it gives you various, different definitions and data. The easy way that I'm going to put it in front of you, it is the injury to the brain. Primary is injury to the brain due to impact from trauma. It is due to impact from trauma. It is the impact from trauma, right? When you talk about secondary brain injury, what is a secondary brain injury? It is the injury to the brain due to the primary injury, right? So it is injury to the brain. It is injury to the brain due to primary injury, right? Due to primary injury. What do you mean by this, right? So whenever there is a traumatic injury where the bleed has occurred, because of the bleed and obviously some amount of damage to the brain parenchyma would have taken place, that itself will result in inflammation, and that inflammation will result in edema. Edema will cause collection of fluid, and that fluid will further increase the intracranial pressure, causing more problem. Now, again, that occurs in a cycle because whatever inflamed part is that will undergo necrosis. Again, it will be more inflammation and more edema and more increase in pressure. As the pressure inside the brain will continue to mount, it will result in more and more brain damage, and that is a secondary brain damage, right? Now, so primary traumatic injuries or the primary brain injuries, I can further classify them into three basic one. One is your concussion injuries, which we normally talk about it. So these are the transient injuries without any actual or deformity noticed in your structural imaging. Another one which I would never want to see on my patient, that is your one of the most devastating part is where there's a decelerating injury. You have COOP, counter COOP injuries that will spoken across, but this is what we call it as the disruption between the white matter and the gray matter. That is going to be your axonal injury or diffuse axonal injury. It is your diffuse axonal injury. And obviously the intracranial hemorrhages and the intracranial hemorrhage and the intracranial hemorrhage, right? Now, in a quick succession, when I say a concussion injury, it is a transient state of confusion. Concussion injury is a transient state of confusion where the patient is confused, but this is short-lived, right? This is reversible. So there is nothing devastating that is going to occur to the patient. And when you do the NCCT to the brain, it comes out to be absolutely normal. So you don't need to worry about it. Diffuse axonal injury is defined as a complete disruption. This is the complete disruption between the white matter and the gray matter of the brain. That is complete disruption of axons. It is the axonal disruption between the white matter and the gray matter. Here, the patient is going to present to you with coma Now, post-trauma, if the patient is landing in coma, when I do the NCCT, for my surprise, it comes out to be normal or any very little focal deficits, which cannot be interpreted with coma. So what I'm going to do, I'm going to do an MRI here, and MRI will have presence of and the gray matter is the characteristic feature of diffuse axonal injury. This is associated with worst prognosis. This is associated with worse prognosis. The multiple images that I've shared across in our regular lectures of PW also, MedEd, where you can find out diffuse axonal injuries, MRI imaging, and how you are going to read across it, right? So this is about your diffuse axonal injury. The one which is exciting for the surgeon is going to be your intracranial hemorrhages. Now let's understand this. Now to understand this, let's say this is the brain parenchyma that we're talking about. Surrounding the brain parenchyma, immediately there is one layer, which is what we call it as the pia mater. The pia mater is inseparable from the brain parenchyma. Surrounding the pia mater, you have the arachnoid membrane, and this is the space where you have your cerebrospinal fluid. The CSF is freely floating between the subarachnoid space. So this is where the CSF is moving across here, right? So between the arachnoid membrane and the pia mater, we have the CSF flowing. Surrounding this, we have the dura, which is present. So this is the dura that is going across here. And covering the dura, you have the skull bone, which is present here. And this is the presentation that we have, right? Now, to make it simple, I'm just going to quickly label it down for you. The innermost layer that we have, this happens to be the pia mater. Then you have the arachnoid. Then we have the arachnoid. Then the outermost that you have is the dura, and the fluid that is floating, it is your CSF fluid that is going across it, right? Now, what are the different sites of hemorrhages and what do we call that, right? Now, the first one that you'll see, it is your intracranial or intraparenchymal hemorrhage. Then if you have here, it is your subarachnoid hemorrhage. This is your subdural hemorrhage, and this happens to be your extradural hemorrhage, right? So this is how the bleeds are going to be present to you. For the labeling part, this happens to be outside the dura, so it is extradural hemorrhage. It is between the dura and the arachnoid membrane, so it is your subdural hemorrhage. This is within the CSF, that is in the subarachnoid space of subarachnoid hemorrhage, and this goes inside the brain parenchyma, so it is an intraparenchymal hemorrhage, right? Now, your MCQ question here is, which of the following is the most common traumatic injury? The overall most common is your intraparenchymal hemorrhage, but one that presents to you with most dramatic presentation or clinically more evidently, that is going to be your extradural hemorrhage, which is going to be an acute presentation. Now, our job is to delineate between the extradural hemorrhage and the subdural hemorrhage in the general sense, but according to the NICE guidelines, let's say a patient has presented to you with post-trauma, right? Post-head injury, the patient has presented to you. Your basic context is, when would you like to do a CT? And if you're deciding to do CT, would you do it immediately or would it take some time or within 8 hours of period? And that is given by your NICE guidelines. So according to the NICE guidelines of CT, you have to decide when would you like to do CT within 1 hour of presentation or CT within 8 hours, right? So within 1 hour, within 8 hours is the two categorizations that we have. When would you like to decide for it? Now, the indications for CT within 1 hour. Now, at any given point, if the GCS, at any given point, if the GCS is less than 13, at any point, then you'll get a CT within 1 hour. If the GCS is less than 15, at the second hour of observation, again, you have to get a CT immediately. Now, if the patient is having focal neurological deficit, if there's presence of focal neurological deficit, if there is an open or depressed skull fracture, open or a depressed skull fracture is noticed, if there is post-traumatic vomiting, even if it is more than or equal to 1 episode, right? And post-traumatic seizure, and if the seizure is even 1 or more than or equal to 1 episode of post-traumatic seizure, this is also an indication for CT within 1 hour. Now, when would you like to do CT within 8 hours? What are the indications for CT within 8 hours of injury, right? Number one, if the age of the patient, elderly patients, age more than 65, right? If there are known coagulopathies. especially if the patient is taking any antiplatelet agents. That becomes very important. Another one is the dangerous mechanism of injury. You have the dangerous mechanism of injury. The dangerous mechanism of injury, right? Along with dangerous mechanism of injury, if the patient presents you with retrograde amnesia for more than 30 minutes. If there is retrograde amnesia, if there is retrograde amnesia for more than 30 minutes, right? See, if a patient had a head injury, right, and he's been brought to the hospital, and you ask him that where did you fall and how did you fall, if he's able to tell it, is fine, right? But if he does not recognize or remember, was he traveling, did he leave his home properly or not, what was he traveling with, who was he traveling with, what was he driving, if those things are not being recalled, then you have to get a CT as early as possible, that is within 8 hours of window, right? So this is the decision making of CT within the first 1 hour or the 8 hours. Both of them has been your previous exam questions, especially your INICET. They've asked you about the protocols, when to get the CT done, right? Now the biggest question is, okay, fine, you've gotten the CT, you've gotten certain diagnosis. Either I would distribute them into an extradural hemorrhage or a subdural hemorrhage. Now, from the exam point of view, let's discuss quickly the differentiating point between these two and then move across with their management per se. Right now, when it comes down to the SDH and EDH, by simple definition, we have already discussed, EDH is the collection of blood, right? We say EDH is the collection of blood between the dura and the skull bone, right? Whereas SDH is a collection of blood. It is the collection of blood between the dura and the arachnoid membrane. Right? So that is the first differentiating point that you will see between the SDH and the EDH, right? Now, usually when the patient comes to you, we have to identify the mode of injury, right? Especially in traumatic injuries, if the patient is having a temporal bone fracture or the temporal fracture. Now, we know the weakest link in your bony prominences in your skull is your temporal side, where your pterion, 3 bony points where they're meeting, that is the weakest point. And that is when it occurs, when the injury occurs on the temporal side, when this bone breaks or this fracture occurs, the fragment can go deeper and injure a vessel that is just running below it. What is the vessel that is running? And that brings down to an interesting question. What is the most common source of bleed, right? What is the most common source of bleed that you can see across here, right? The most common source of bleed is going to be your middle meningeal artery, which is going to be running right below it, right? Whereas in terms of mode of injury, that is going to be for your subdural hemorrhage, it is usually because of there has to be a significant history of fall, hit, or blow to the head. Usually it occurs in elderly patients, and the most common source is going to be your cortical bridging veins. Here it is because of the cortical bridging veins. Now, as we can see, the arteries are going to bleed profusely and the veins are going to take their own sweet time, but yet the symptomatic arrangements will be seen thereafter. Now, when you talk about the clinical presentation with respect to your extradural hemorrhage and the subdural hemorrhage, remember it will be acute in presentation and this will be gradual in presentation. So the presentation is will be more gradual in SDH. EDH will have more acute or more dramatic presentation. Both of them have features of raised intracranial pressure. You will see the raised intracranial pressure is seen in both components, right? Now, when I say raised intracranial pressure features, obviously the standard features that you have, the patient will have history of vomiting. There could be post-traumatic seizures that can be seen across you. There will be visual abnormality or disturbances. Same findings will also be seen in this, but this will be more gradual in presentation, right? Now, one differentiating factor that you see in extradural hemorrhage is presence of lucid interval. It is the presence of the lucid interval. Now, in which way can I explain you lucid interval, the best possible scenario? lucid interval is defined as the period of consciousness between two unconscious episodes, right? You need to understand this way. As soon as the patient is hit, the median meningeal artery bleeds, there is sudden bleed that occurs, that sudden increase in intracranial pressure will result the patient to lose consciousness, right? But again, there's a tamponade effect. All that hematoma that is formed will itself converge onto the bleeding vessel to stop the bleed. Patient regains consciousness, starts moving around. When he starts moving around, again, the clot disrupts, rebleeds, again, pressure increases, patient becomes unconscious. So the lucid interval is described as the period of consciousness. It is a period of consciousness between two unconscious episodes. Between two unconscious episodes. And this is what we call it as the lucid interval. That is a characteristic feature of your extradural hemorrhage, right? Now, in subdural hemorrhage, you can see because of raised intracranial pressure, there could be a dilated pupil, whichever side the bleed is there. And this is usually remaining restricted and confined, right? Now, either ways, when you have a traumatic brain injury and the patient is brought to you, one of the most interesting feature that you will see in your subdural hemorrhage is going to be your headache. And this headache is not responding to management, right? So patient says there's a gradual buildup of headache, no matter what medicine he's taking, is not able to get through it. So that also indicates it could be a chronic variant of the subdural hemorrhage as well. But nevertheless, if we go across with the investigations, the investigation of choice for both of them is
Guys, there seems to be a technical issue. So let me connect with Dr. Sandeep. We'll be back soon. So hang in there. We will be back and we will be continuing our discussion.
am I back, sir?
Yeah, you're back. You can proceed.
Oh, sorry. 1 sec. One second, sir.
Yeah, sure.
Okay. Screen is all right. Can I go?
Yeah, I think you can proceed.
Okay. Right. So we're talking about the NCCT of the brain. When you do for your extradural hemorrhage, you will see the blood is going to get collected between the skull bone and the dura. Now, skull bone is not going to budge because of the brain, because of the bleed. So the entire pressure that is going to be present, that pressure will be mounting and it will be exerting onto the brain parenchyma. And this is the shape of the opacity or the the clot that you will see across here. And this is given a fancy names, right? We call it as the columns of management. Now, in emergency, I would like to release the pressure. That is going to be the burr hole surgery would be done. But we would like to do craniotomy, and the recent guidelines for the indication of craniotomy. The indications of craniotomy, that is a 2022 WHO guidelines, have been approved for craniotomy in these patients for the following context. Number one, if the size of the clot is more than 30 cc in total volume, if it is more than 1.5 centimeters, cerebri is going to move to the other side, and that is what we call as midline shift. And if there is a midline shift of more than 5 millimeters, it is more than 5 millimeters in midline shift. In the midline shift, This is the indication for craniotomy for the current scenarios for extradural hemorrhage, right? Now, in the subdural hemorrhage, again, everything remains the same. Again, this is your flak cerebri. This is the cerebellum, right? So in the same context, and this is the brainstem. Let's say this happens to be the concept here. I'll just say this happens to be the dura, just to tell you that it is going to be subdural and it is going to be between the arachnoid membrane. So let's say this is the arachnoid membrane that we are trying to show across here. Now here you will see I'm going to show the bleed in the blue color, telling you that's a venous bleed. It will take more of the shape here. As more and more volume will increase, it is going to cause more and more amount of pressure, right? So this, as one side you can say concave, another one is convex. This is what we call it as convex opacity. It is a concavo-convex opacity, which is also called as the crescent opacity. It is also called as the crescent opacity, right? So what are the current guidelines for intervention, right? So the indication for craniotomy. Indication for craniotomy. The indication for craniotomy in these patients. Number one, if the patient presents to you with fixed dilated pupil, if there is a fixed and a dilated pupil is present, if it is more than 1 centimeter in thickness, if it is more than 1 centimeter in thickness, more than 5 millimeters of midline shift, more than 5 millimeters of midline shift, and if the GCS is less than 30, and if the intracranial pressure is more than 20 millimeters of mercury. That brings down to me an interesting question. What is your normal intracranial pressure? The normal intracranial pressure is going to be 5 to 15 millimeters of mercury. The normal intracranial pressure is going to be 5 to 15 millimeters of mercury. And this is the indications for intervention wherever you get these particular injuries, right? Now, another interesting factor that you will talk about is going to be your secondary brain injuries that we have spoken across. Now, the secondary brain injury, I told you it is because of primary brain injury itself, right? So it is going to be because of raised intracranial pressure. So I can simply say it is because of raised intracranial pressure due to primary traumatic brain injury. Now, this primary traumatic brain injury is basically resulting in cerebral edema. It is resulting in cerebral edema, and this cerebral edema is raising or increasing the intracranial pressure, right? Now, let's understand how this whole cycle impacts, right? Now, you need to understand, in order to basically conclude everything, you need to understand how brain is perfused, and the perfusion is what we call it as the cerebral perfusion pressure. How do you calculate the cerebral perfusion pressure? It is calculated as mean arterial pressure minus intracranial pressure, right? Now, we say in order to calculate the mean arterial pressure and the intracranial pressure, if you subtract it, you get the cerebral perfusion pressure. It is the pressure required to perfuse the brain. Now, we already know that the normal intracranial pressure is going to be 5 to 15 millimeters of mercury pressure. It is going to be 5 to 15 millimeters of mercury pressure. Is it any technical glitch?
The stream is little slow, but I think students should be able to understand.
My end, it looks a bit of lagged out. One sec. So my internet is stable. Yeah. Okay. Cool. Can you see the word?
Yeah. 5 to 15 millimeters of mercury.
Just in case.
It's visible.
Okay. Done. Cool. Right. Sorry. So cerebral perfusion pressure is the pressure required to perfuse the brain. The normal intracranial pressure is 5 to 15. The normal mean arterial pressure is going to vary anywhere between 90 to 110 millimeters of mercury. That gives me a normal cerebral perfusion pressure of 75 to 105 millimeters of mercury pressure. Okay. So this is the basic concept that you have. Now, when the intracranial pressure is going to increase, now imagine if the intracranial pressure is going to increase, the net value of the cerebral perfusion pressure will decrease. Now, here is the concept. Remember, the minimum CPP required to adequately perfuse the brain should be more than or equal to 65 millimeters of mercury pressure, right? Earlier it was 60. Now the latest data says it should be more than or equal to 65 millimeters of mercury pressure. If the pressure is less than 65, this will result in inadequate business. I am a great fighter. I'm not going to quit with this, right? So in the same context, we say cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. The intracranial pressure is increasing. It is causing decrease in CPP. Body says, I'm going to fight back. How do fight back? It is going to say, I'm going to increase the mean arterial perfusion pressure, neutralizing this to keep the CPP normal. I said, great. Now we ask body, dude, how are you going to increase the mean arterial pressure? It says the mean arterial pressure is a component of the systolic blood pressure and the diastolic blood pressure. I say it is 1/3 of systolic and 2/3 of diastolic blood pressure, right? Now we said, okay, fine. How do you plan to do that? The objective is to increase the systolic blood pressure. I said, great. How would you increase systolic blood pressure? Now, what is blood pressure? It is the pressure exerted by the volume of the blood onto the lateral walls of the vessel. So we're talking about volume of the blood has to be increased. Then only systolic blood pressure will increase. I said, okay, great. How would you increase the volume of the blood? Now, here is the context. Now, in order to increase the systolic blood pressure, we have two components that we have. Either you increase the volume of the blood or you decrease the size of the vessel. Either way, the pressure will increase. What is the blood pressure? It is the pressure exerted on the lateral walls of the vessel. Either I can increase the volume of the blood in the vessel to increase the pressure or decrease the size. Now, if I choose to decrease the size, the pressure will increase, but the volume of blood going to the brain will still not improve. So the ischemia will not improve. So in order to overcome that, I am not going to constrict the blood vessel. In fact, I will increase the volume of blood required to increase the pressure. I said, how is that possible? You can't beg around for blood from other people. No. So body says, I have a beautiful idea. Now, in order to understand this, we have a concept which is called as cardiac output. The cardiac output is preload minus afterload, right? Now, if I increase the cardiac output, that means the blood going from the left ventricle into the aorta will increase. If the volume of blood from the left ventricle to the aorta will increase, obviously the pressure will also increase. In order to do this, now this is the amount of blood that is available in the left ventricle, and this is what we call it as preload, right? Now, my objective in order to increase the, what is a preload? It is the amount of blood available in left ventricle before the contraction. What is afterload? It is the amount of blood left in the left ventricle after contraction, right? So in order to increase the cardiac output, I have to increase the preload, right? Now, in order to increase the preload, what do you have to do? I have to allow the left ventricle to fill for longer duration of time so that more amount of blood can come into the left ventricle. So I am going to increase the diastolic filling time. I'm going to increase the diastolic filling time so that the volume of blood in the left ventricle will increase. And if the cardiac output will increase, the systolic blood pressure will increase, which will result in hypertension. But the problem is, as the amount of blood is going to come into the left ventricle, the time taken for the left ventricle to fill will increase. So what will happen to rate at which the heart is going to contract? It will decrease. So that will decrease in heart rate. That will result in bradycardia. And because of raised intracranial pressure, there will be irregular respiratory rate. Call it as, yes, it is your Cushing's triad. It is going to be a Cushing's triad. Now, what does Cushing's triad signify? The Cushing's triad signifies that there is traumatic brain injury causing increase in intracranial pressure. So all increased intracranial pressures will present to you with Cushing's triad, right? So this is the concept that you have to follow. How would you manage, right? Now, there has been various parameters and protocols that are to be laid down. We'll make it very simple for us to understand the management for secondary brain injuries. Number one, now my objective is to decrease the intracranial pressure, and I have to make sure the pressure load on the head should decrease down. Now for that, number one, I will start the patient on IV mannitol. This will decrease the cerebral edema. I will oxygenate the patient, obviously intubate. Now, there is one protocol that says hyperventilate the patient, right? Now, here I would like to take a little bit of opinion from Santosh sir. Sir, the guideline says hyperventilation is now not recommended. Earlier, we used to say hyperventilation will cause carbon dioxide washout. Carbon dioxide washout will result in respiratory alkalosis. Respiratory alkalosis will cause depression of choroid plexus, CSF production will decrease, and the intracranial pressure will decrease, right? Now it has been questionable. Any update from the medicine point of view, sir?
The standard medicine texts still continue to debate about the role of hyperventilation, but the major harm is not also proven. So as of now, the medicine textbooks recommend it, but not a strong recommendation. The level of recommendation is more of a postgraduate discussion. So for undergrad students, what I would suggest is, it is one of the strategy available at your disposal, right? So you might use it because there is no strong recommendation against it. The benefit is now questionable, but as of now, it still remains one of the recommendations from the perspective of medicine.
Thank you, sir. So these are the components that we have. We start IV mannitol, oxygenate the patient, intubate. We have to do an head and elevation. We do an head and elevation, and you need to maintain your key parameters. That is an exam question. What are the key parameters that you have? Number one, the partial pressure of carbon dioxide, that has to be maintained at 4.5 to 5 kilopascals, right? This is the first key parameter that you have to maintain in your ICU. The second key parameters is the partial pressure of oxygen. Now, the partial pressure of oxygen should be maintained above 11 kilopascals, right? Now, your cerebral perfusion pressure. Now, CPP has to be maintained. As we told you, CPP should be more than or equal to 65. So CPP has to be maintained of more than or equal to 65 millimeters of mercury. This is another key parameter that you have. The mean arterial pressure should be maintained between 80 to 90 millimeters of mercury. And your serum, that is your sodium and potassium levels, has to be constantly monitored. The sodium should be maintained at more than 140 millimoles per liter, and the potassium should be maintained at 4 millimoles per liter. Should be more than 4 millimoles per liter. These are the key parameters that you have to give absolute importance when you're maintaining the patient in ICU, right? So this is about your traumatic brain injuries and their key management strategies, right? So this is from my end in terms of your acute neurological disorders or the acute neurological injuries that we can mend across, right? So over to Santosh, sir. Thank you, sir.
Okay, so guys, only one or two more points to be added here. Number one, there can be an MCQ asking you what is the most common non-traumatic cause for intracranial bleed, and your answer should obviously be hypertension. And if hypertension is the most common cause for intracranial bleed without a trauma, they can also ask you what is the most common site where hypertensive bleed can happen, and your answer should be putamen. The rest of the things we will discuss in the sessions where we will discuss hypertensive emergencies. Just be aware that the most common non-traumatic cause for the intracranial bleed is hypertension, and particularly the intraparenchymal, and the most common site for hypertensive bleed is putamen. Okay. Now, guys, if you've watched the entire session, there's one important take-home message. See, we have spoken about a lot of numbers, and this is one topic where you need to remember those numbers absolutely, because MCQs are going to be focused on this, mostly about how do you manage, what are the indications, what are the contraindications, and if there are some specific measures, like in this case, Sandeep sir has given you the numbers for the partial pressure of carbon dioxide, oxygen. Those numbers are absolutely important and you need to remember. Generally, what I say is numbers, drug dosages are not very important when it comes to the NEET PG, but there are some areas where numbers become absolutely important. Like this is one of them. Then when it comes to medicine, the ARDS, ventilatory settings, there are a lot of numbers to remember. So the take-home message is, please remember the indications and contraindications of various things that we have discussed today and some of the important numbers. Otherwise, there is nothing much conceptually to understand here. It's most about remembering the information. Over to you, Sandeep sir, if you want to add anything to.
No, sir, thank you. Absolutely scintillating session. Enjoyed it. Hope this brings a lot of, topics which you're going to read in different subjects. And now it has been clubbed together and put at one place. So it's a beautiful resource for you to test yourself, understand, analyze, and start doing your questions as well, right? So keep using this. We will come up with much more interesting videos with more scenarios, and will come in future as well. So what is Santosh sir from my end? Thank you guys. Thank you so much.
Okay guys, so we are signing off. We will be connecting every day at 7 p.m. discussing various important topics. The first run is for the neurology. So tomorrow also we will be connecting again, taking one more important topic. So stay tuned and don't forget to solve MCQs. right, is as important as listening and reading is solving MCQs. So don't miss out on that and try to apply what you learned in today's session on your MCQs, and hopefully you will remember things better. So with that, signing off, guys. See you tomorrow at 7 p.m. MedEd channel. Thank you. Thank you, sir.
Thank you, guys. Thank you. Bye-bye. Thank you.
Bye, everybody.